we're going to talk about diuretics. Okay, so this is our next category of drugs for this test. And we have 4 different drug classes in diuretics. Loops, osmotics, thiazide, and thiazide-like drugs, but for this purpose, we're just going to have thiazide, and then potassium-sparing. All diuretics can be used for hypertension, heart failure, and renal failure. They all work in the kidney, and they all increase urine formation time, and they're going to help remove sodium and water. Generally, diuretics are inexpensive, and they have a pretty short half-life, so they're pretty safe. So they're classified based on where they work in the nephron, and we're going to talk about those specific locations in just a second. But generally, the more potent diuretics are going to be loops, followed by osmotics, then thiazide and thiazide-like diuretics, and then potassium-sparing. So the most potent are going to be the loops, least potent are potassium-sparing. So I'm going to let you look at it just for a second. I don't know if you're going to be able to see the whole thing. Hopefully you can pause it or whatever. And as usual, I'm going to mispronounce these drug names, but whatever. We're going to live our life. Okay, so the first category are loops. Again, they are the most potent. The 2 drugs here are butanide and furosemide. I'm saying them wrong. Bumex and Lasix are the brand names. These drugs are going to work in the loop of Henle. They're going to help block sodium and chloride reabsorption. So right here. They can be used for edema and hypercalcemia. Edema, especially related to heart failure. This is they can also work for peripheral edema and pulmonary edema. This really works well for when you need to remove a lot of fluid quickly from a patient. Nursing implications for loop diuretics include take in the morning. This can help prevent bathroom trips in the evening for your patient. So take it in the morning. You do need to take caution in the elderly because they can get easily dehydrated. And these drugs can work in kidney failure because they're so potent. For kidney failure, you need to remember that it's diminished kidney function and not poor renal perfusion. So diminished kidney function is going to be kind of like if you think of your kidney kind of like a colander, some of the holes are clogged in the colander. These drugs will keep working when the kidney is not working well. But if there's poor blood flow to the kidney, it doesn't matter how many holes are open in the kidney, which would be the colander. If blood can't get to the colander, nothing's going to get filtered out. So remember, loop diuretics can work with poor kidney function, but not poor renal perfusion. Renal perfusion meaning blood going towards the kidneys. Hopefully that makes sense. I just think of the kidney as like a colander, and poor kidney function is like some of the holes in the colander are plugged up with whatever. So it can still filter stuff, but it's just not going to filter as quickly. And then you think of like renal perfusion being like the blood getting to the colander, which is also a really gross way to think about it, but whatever. I think of it that way and it helps me. Hopefully that makes sense. It's not like you're thinking of like a bloody colander now. Okay, I'm getting off on a tangent, whatever. Okay, loop diuretics are contraindicated in patients who have a hepatic coma, severe electrolyte loss, or a sulfa drug allergy. Remember, this is one of those drugs that can be related to sulfana. I can't say it. Just need to know if your patient has a sulfa drug allergy. Just something to know. Adverse effects of loop diuretics include hypokalemia, which is low potassium. So you're going to need to give your patient a potassium supplement or at least monitor their potassium levels. Ototoxicity, neurotoxicity, and nephrotoxicity. So oto being ear, neuro meaning brain, nephron meaning kidney. So if you think of a kidney, which is, I can't draw the shape, but it's kind of like the same shape of an ear, oto, nephron, you're going to think, okay, ear, kidney toxicity, as well as neurotoxicity. There is an adverse effect also includes digoxin toxicity, which can lead to arrhythmias. So if your patient is taking digoxin or something else that can cause digoxin toxicity, this too can add to that fire. It can also increase uric acid and uric glucose, and not uric glucose, uric acid and glucose levels. So you need to watch out for if your patient has gout or if they have diabetes. You just need to take caution when using these. And it can also lead to the adverse reaction of a skin rash, which this is mainly when the patient has a sulfa allergy. This drug, loop diuretics, you can combine with other diuretics. So loop diuretics can be used with other diuretics. The response that you'll see with a loop diuretic is that you'll see lower blood pressure and lower vascular resistance, especially if you're giving for hypertension or heart failure. And since we did talk about earlier that you need to know your patient's potassium level, the normal potassium level is 3.5 to 5. So remember, we have hypokalemia here, which is low potassium. You need to monitor your patient's potassium levels, possibly give them a potassium supplement. The normal range is 3.5 to 5. Just remember that. Okay, the next class, which is a little bit less potent than the loop, is osmotic diuretics. This drug is mannitol, and the brand name is Osmotrol. I can say it. I'm pretty sure I said this correctly, so pat myself on the back. These drugs work in the proximal tubule and the descending loop of Henle. It's going to increase osmotic pressure, and it's going to stop water reabsorption, but there also can be a slight electrolyte loss. So osmotics work in the proximal tubule and the descending loop. Loops work in the loop of Henle. So that's pretty easy. Osmotics can be used for patients who are not urinating. This is also called I'm not going to say it right. Oliguria. There's the word. Oliguria. That sounds right. Sure. And it can also decrease intracerebral pressure because of cerebral edema or trauma. It can also help excrete toxic substances, and it can be used in early renal failure. A nursing implication for osmotic diuretics is that it can only be taken parenterally and not orally, and that these drugs, osmotics, may crystallize at low temperatures. So the nurses, whenever they're administering this drug, they need to check the drug before they load it up into the IV, because you wouldn't want to give a crystallized drug to somebody. That would just not be a good thing. Contraindications in osmotic diuretics include severe renal disease, pulmonary edema, because it does not decrease extracellular fluid, patients who have an active intracranial bleed, or peripheral edema. So peripheral edema, yes in loops, no in osmotics. The adverse effects for osmotic diuretics include convulsions, thrombophlebitis, pulmonary congestion, and an exfoliative dermatitis. Our teacher didn't really get much into that, but just something you should know. The response that you'll see with the osmotic diuretic is vasodilation, increased glomerular filtration rate, decreased intracerebral pressure, and decreased intraocular pressure. So patients with glaucoma, they can see a little bit of relief with that. For thiazide and thiazide-like diuretics, they are going to be working in the distal convoluted tubules. So over here, we have proximal and the descending loop of Henle. This one is in the distal convoluted tubule. So if you think of the nephron in the kidney, you're kind of just going down. Well, let me go back this way. So if you start over here, you have the loop of Henle. Well, that's going to be down here. You'll have the descending loop, ascending. So now we're working over here. We're in the convoluted tubule. The two drugs are hydrochlorothiazide and metalazone. Metalazone, maybe that's how you say it. I don't know. Hydrochlorothiazide is also often abbreviated HCTZ. The brand name is Esidrix or Hydrodurel. I don't know. And then metalazone is Zarloxolin. Not saying it right, but that's how you spell those words. These drugs are going to help reabsorb sodium, potassium, and chloride in the body. They're going to relax small blood vessels, decrease peripheral vascular resistance, decrease preload and filling pressures, and help water. They can be used for heart failure, hypertension, edema, idiopathic hypercalciuria. I guess that's how you say it. I don't really know. Diabetes insipidus and hepatic cirrhosis. A nursing implication is that you need to check your patient for a sulfa drug allergy. Always checking. Contraindicated in patients with anuria, which would be little urine. Remember, oliguria, however you say it, that's no urination. And anuria is a little. So you can think of a little anuria. It's also contraindicated in patients who have severe renal failure. Interactions with thiazide and thiazide-like diuretics include corticosteroids, digoxin, and oral hypoglycemics. So it's kind of another nursing application that you need to know about if your patient's on one of those. Adverse effects include hypokalemia, headache, dizziness, increased calcium levels, increased lipids, increased glucose, and increased uric acid. So it can increase all four of those lovely little things. And hopefully the response that you'll see when your patient is taking this drug is that they'll have a decreased level of edema, decreased heart failure, and decreased hypertension. You do need to note that thiazide and thiazide-like diuretics do have a ceiling effect. Can you see it? Can you see it? Can you see it? They have a ceiling effect. So once they get to this certain level, they're not going to get any higher. They're going to stop here because this is the ceiling. Okay, the next section or the next category are potassium-sparing diuretics. These work in the collecting ducts and the distal convoluted tubules. The drug here is spironolactone. I don't know how to say it. Aldactone is the brand name. These are going to block aldosterone receptors. So sodium and water will be excreted, but potassium won't be. Potassium will be held onto. I mean, come on now. It's called potassium-sparing diuretics. These drugs can be used for hyperaldosteronism, hypertension. They can help reverse potassium loss. They can help with ascites from liver failure, heart failure because of diastolic dysfunction. With potassium-sparing diuretics, you need to watch for hyperkalemia because your body is holding on to the potassium instead of excreting it. So obviously increased levels of potassium can happen. And the amount of potassium that's going into the cells is increasing. So again, watch for hyperkalemia. Hyperkalemia is considered any level that's 5.5 or above. Remember, potassium's normal level is 3.5 to 5. When we asked our teacher in class what would be considered hyperkalemic, she said 5.5, but I guess it could change depending on what school you're at or what your doctor or wherever you are, what they consider hyperkalemic. But for us at our school, we're thinking 5.5 and above. Although our teachers did say they wouldn't ever give us like the options to choose from on the test, like 5.6 or 5.1, because technically they're all above that 3.5 to 5 level. They would probably be like, they'd give you the option of like 6 or 7 instead of something so close to 5 itself. Okay, sorry, a little tangent. Other things that are contraindicated with potassium-sparing diuretics, hyperkalemia. If your patient is already hyperkalemic, you're obviously not going to give them this. And if they have severe renal failure, and again, anuria, if they have very little amounts of urine being produced. Adverse effects can include dizziness, headache, GI issues, and the response that you'll see if your patient is taking a potassium-sparing diuretic would be decreased edema, decreased heart failure, and decreased hypertension. Again, that's what we're giving it for, so hopefully we'll see one of those will be being decreased. For all diuretics, when you assess your patient, you need to make sure you get a full medical history and possibly a physical assessment. You test their skin turgor, you look for signs of edema, you're checking the moisture of their mucous membranes to see if they're dehydrated or not, testing capillary refill, asking your patient about their bowel movements to see if they're constipated, look for weight, like monitor their weight to see how much weight they're losing or how much weight they're gaining, depending on if they're edemic or not. And you also want to watch their liver labs, especially their potassium levels. When you give patients these drugs, implementation things that you're going to want to remember is you want to have your patient take this medicine in the morning to stop and prevent bathroom trips at night. You also want to watch for making sure that the path from the bed to the bathroom or wherever they are, the path to the bathroom is clear so that you can help prevent falls. And you're also going to watch out for the signs and symptoms of hyper and hypokalemia. You want to take caution in hot climates because patients can become more dehydrated easily. And if needed, give your patient potassium supplements. You're more likely to give your patient potassium supplements over here than obviously with potassium sparing, because they'll have too much potassium or they won't have enough potassium. So just something to think about. Evaluation for diuretics, you're going to want to see a decrease of edema, fluid volume overload, heart failure, blood pressure, and you're going to want to see if they have increased intraocular blood pressure, that it would be returning to normal. Those are for the patients with glaucoma. Teaching points would include proper nutrition, eating vitamin K rich foods, not vitamin K, potassium rich foods. I just have K written right here. It's not supposed to be vitamin K. It's potassium because potassium is K, but whatever. So eating potassium-rich foods. Make sure your patient knows about the digoxin but give them a digoxin warning that don't take digoxin when you're on some of these drugs because there can be an interaction, and also monitor blood glucose levels. So those are the 4 categories of diuretics. Remember that loop diuretics are the most potent. Potassium sparing are the least potent. It goes in this order. So most potent here, least potent, well, not least potent, less potent, even less potent, least potent diuretics. So loop is strong, potassium is weak. These 2 puppies in the middle are weak but a little strong, strong but a little weak, weak but a little strong, really weak, really strong. I think that's going to confuse y'all, but hopefully this can help. And yeah, you just kind of got to remember that they go in this order. LOTP, lots. Ooh, we could do that. LOTS for sparing. LOTS. So diuretics, you might need to take lots of diuretics. L being the most potent, O being less, even less potent, least potent. So there you go. Hopefully this helps. Hopefully you can see the paper.